All right, folks, thanks so much for joining us this afternoon as we review what FIT 2.0 looks like here in Ontario. That started about 2 days ago. We didn't want to have a presentation on July 1st, given that was a holiday, so we figured why not just take up your Friday afternoon instead. Um, I'm Neil Nayak. I'm your Regional Primary Care Cancer Screening and Prevention Lead for Waterloo Wellington, and it's my pleasure to be able to do this for the region. We'll start off with our land acknowledgement. I'd like to begin by acknowledging that we gather today from many parts of what is now called Waterloo Wellington region. Traditionally, this area was a gathering place for many nations. I acknowledge that I am situated on the Haldeman Tract, land that was promised to the Haudenosaunee of the Six Nations of the Grand River, and is within the traditional territory of the Neutral, Anishinaabeg, and Haudenosaunee peoples. We're grateful for the opportunity to live, meet, and work on this territory, and we reflect on the principles of reconciliation and strive to incorporate them into our work. For today's presentation, feel free to use the chat to ask questions or raise your hand. I can see raised hands and I can see the chat. Feel free to interrupt in the middle of the presentation. I do not mind. This presentation is being recorded for our colleagues who aren't able to make it today for this meeting. Just a heads up, in case you do turn on your video camera, that it is being recorded. In terms of this is an accredited talk for 1.0 FTE. We are taking attendance, and in addition to that, there will be an evaluation at the end for you to complete. You need to complete the evaluation in order for you to receive the credits, and that will be at the end of this presentation for the QR code. And so the recordings are not eligible for accreditation, unfortunately. In terms of faculty disclosures, this is me, Neil Nayak. In terms of relevant commercial interests, Neil, in terms of grants, I have received honorariums from Merck and consulting fees from Merck and Pfizer. In addition to that, I do get paid for the Waterloo Wellington Regional Cancer Program to be the RPCL for this region, as well as from Ontario Health, who then funds the Regional Cancer Program, but I'm also the clinical lead for OH West. This program has received financial support from Ontario Health in the form of payment for the certification of this module. And the program has received in-kind support from the Regional Cancer Program and all three OHTs in the form of communication and logistical support. And we're greatly, immensely thankful for the help that we've received to get this off the ground. In terms of disclosures of those commercial supports, Ontario Health does benefit from increased screening rates that will be discussed in this program, and that I have also received funding from the Regional Cancer Program and Ontario Health, and it is part of my deliverables to increase screening rates in the region, for which I get paid for. The way we mitigated potential bias here is that we used evidence-based content, or the steering committee did, and that scientific planning committee reviewed the presentation, and if any bias arose, the SPC discussed and reviewed that perceived bias. If you see any bias whatsoever in this presentation, please do email primarycareinquiries@ontariohealth.ca. This program is not my opinion, but uses evidence-based content developed by Ontario Health. I have not modified the slides in any way, except for adding one slide at the end to tell you about the accreditation link, as well as putting in my disclosures at the beginning. There are many gender identities. Inclusive language can help screen eligible people to help them understand whether screening is the right for them. In the case of colorectal cancer screening, it is meant for all genders. And so it does help quite a bit in regards to helping with that gender piece. In addition to that, though, if there is any terminology that identifies a binary gender, it is solely from the fact that it comes from scientific papers and statistics, and does not represent the opinion of myself or represents the position that Ontario Health has. All right. This program was built into modules, just so you're aware. We will be going over module 1. And so at the end of this module, we'll be talking about what colorectal cancer in Ontario is. We won't spend too much time on that because I expect and anticipate that most of you already know this, what those changes are from July 1st, and what resources are available for you. So we won't spend too much time here. Feel free to throw your answers in the chat if you'd like to. But rank from highest to lowest, number of cancer-related deaths diagnosed in Ontario in 2024 by type in males and females combined. Breast, female only, pancreas, colorectal, or lung. Give you guys about 10 seconds before I give you the answer. And you can also just have it on a notepad next to you. It's very much just for self-learning in this case. All right, so the answer here is that lung had the most number of cancer-related deaths in Ontario in 2024 at 6,852. Number 2 was colorectal at 3,200, so lung was almost more than 2 times the amount of colorectal. Then pancreas at 2,200, and then breast at 2,100 deaths. Second question here is, if caught in stage 1, approximately blank of people with colorectal cancer will have survived at 5 years. All right, so the answer here is 90%. If we can capture patients at stage 1 of their cancer, 90% will survive to 5 years. If colorectal cancer is diagnosed later, it can be treated, but surviving is less likely. Only about 1 person out of 8, or 13%, with colorectal cancer diagnosed at a later stage 4 will have survived at 5 years, which is why screening is so important. And then finally, the last question here is, of the people diagnosed with colorectal cancer in Ontario, approximately blank have no family history of the disease. Give you about 10 seconds to answer that in your own head, or throw in the chat if you're feeling brave. The answer is C, 70%. Research shows that almost 70% of people diagnosed with colorectal cancer have no family history of the disease. And so it is a common misconception that people have a family history that puts them at an increased risk. It varies, and we'll go over that today. So colorectal cancer accounts for 10% of all cancer deaths in Ontario. The lifetime probability of developing colorectal cancer is 1 in 22. And like I said earlier, if caught early, it can be cured. There is, like all cancers, there are disparities in the burden of disease for colorectal cancer. Some sociodemographic groups are worse off than others in terms of their health status. These disparities may stem from structural and systemic factors, including income, education, social support, neighborhood disadvantage, just to name a few. And sociodemographic data is not routinely collected in Ontario, so it's not possible to confidently identify which groups have higher burden. However, there are specific databases that identify Indigenous populations, which makes data collection and monitoring possible. So colorectal cancer incident rates in First Nations people in Ontario are higher than the rest of Ontario. First Nations people also have higher mortality rates and a lower chance of survival following a diagnosis. In Métis populations, colorectal cancer incidence rates are lower for females than other females in Canada. However, in the Inuit and Nunangat populations, incidence rates are higher compared to the rest of Canada. And while we don't have any reserves here in the Waterloo-Wellington region, we do have a substantial Indigenous population in all 3 OHTs. I believe the last census that I heard from the OHT is we approximately have anywhere from 70 to 90,000 Indigenous individuals. Just not everyone identifies it when they come see their clinician. And so it's really important that we have this in mind should somebody choose to ask, hey, what screenings can they do? And if they identify as Indigenous. Screening rates are lower among Indigenous people in Ontario compared to the rest of Ontario. Compared to other people in Ontario, First Nations people have completed fewer fecal tests over their lifetime, were less likely to have a follow-up after an abnormal screening test, and became up to date with screening more slowly, and spent fewer years up to date with screening guidelines. Screening rates are lower in Métis people as well. And data on screening rates in Inuit populations in Ontario are not available. However, when we look across Canada, There are higher proportions of Inuit populations, where there are higher proportions of Inuit populations, more people are overdue for screening than the average Canadian. So colorectal cancer screening or colon cancer check is Ontario's organized CRC or colorectal cancer screening program. It was launched in Canada, was first in Canada and launched in 2008. The goal of the program is to reduce people's risk of developing or dying from colorectal cancer. It aims to achieve this goal by increasing the percentage of people who get screened regularly and who have timely and appropriate follow-up. And as an organized screening program, letters to eligible people are sent, including invitations, recalls, reminders, and results. And screening is offered to eligible people through their primary care provider. So we're going to cover eligibility criteria, upcoming changes, or recent changes, my apologies, it's already passed, and screening recommendations and any of those changes that have happened in terms of what it constitutes as increased risk now. In regards to population-based screening, the goal here is that we're going away from opportunistic screening, which puts the onus on the patient or provider to initiate the conversation. And organized screening puts the onus on the system. It runs centrally, uses clear, consistent policies and processes, and uses scientific evidence to determine who gets screened and with what device. Colon cancer check, the program itself, is an example of where we have a defined target population. We send letters out to eligible patients to invite them or to recall them, and then monitors on performance across the system. So things that we'll monitor for is not just screening rates, but how long does it take for that person with a positive FIT test to get a colonoscopy? How long does it take from colonoscopy to get treatment? How long did it take for the pathology results to come through? These are all things that we monitor, which is why it's so important for us to get it right. In terms of key changes as of July 1st, there are multiple. One is we've lowered the screening rate age from 50 to 45. Two, there's updated eligibility criteria for people with a family history of colorectal cancer, which shifts some people from increased risk down to average risk. 3, we have a new laboratory and device vendors for FIT. And 4, they've enhanced the process so that there's less lost FIT kits, but also less administrative burden on primary care. So we'll start off with average risk. Everything in purple represents changes that have happened from July 1st. So FIT is recommended for people ages 45 to 74 who have no personal history of colorectal cancer, precancerous polyps needing surveillance, Crohn's disease, or ulcerative colitis. No first-degree relatives diagnosed with colorectal cancer, or only one, or any first-degree relative who had a colorectal cancer at the age of 60 and above, and that's another big change. If you had a relative that was diagnosed with colorectal cancer at the age of 60 or older, it is considered that you are average risk. The remaining changes are still factors on family history remain the same. So one or more first-degree relatives diagnosed with colorectal polyps, including high-risk adenomas, or one or more second-degree relatives, including grandparents, grandchildren, siblings, nibblings, so nieces and nephews, and piblings, aunts and uncles, diagnosed with colorectal cancer or colorectal polyps at any age. Increased risk eligibility. So here again, in purple are those changes. So it's recommended to start at the age of 40 or 10 years earlier than the age of their youngest relative that was diagnosed with colorectal cancer, whichever comes first. And so that means colorectal cancer before the age of 60, just to continue on that same theme of what we talked about at the last slide. So if they have a first-degree relative that got diagnosed at the age of 55, the screening age start will still be 40. But if they were diagnosed at the age of 45, the screening age would be 35. If they have 2 or more first-degree relatives diagnosed with colorectal cancer at any age, doesn't matter what the 60 piece, just any age, it's increased risk. Just the same as before. In addition to that, you need to have OHIP coverage for the colon cancer check program. It doesn't mean that people with no OHIP coverage can't get checked for a FIT test. You just got to double check with their UHIP or IHCP coverage or any other insurance coverage that they have. They need to be asymptomatic. If they're symptomatic, they need to get a scope done. And they need to be due for screening. So no prior screening or had negative FIT more than 2 years ago, or had a colonoscopy more than 10 years ago, or had a colonoscopy with findings of 1 or 2 low risk adenomas, 5 or more years ago. It should not be used as a diagnostic, FIT tests should not be used as a diagnostic workup of patients, as you're probably delaying care for that patient when the referral needs to be sent in. There are private pay options to purchase for FIT tests. For those who have interim federal health program coverage or IFHP, there's more information on ICL's website. That's our lab that's going to be that is providing us with our FIT tests, and here's the link should you wish to explore it. All right. And we discussed this already. These are common symptoms of colorectal cancer. If they have these symptoms, please do not order a FIT test. They need a colonoscopy. So let's go over the evidence as to why we lowered the start age. So as I mentioned, as of July 1st, the screening start age is lowering from 50 to 45. And for increased risk, it's lowering from 50 to 40. However, if the person's relative was diagnosed before the age of 40, they should still start screening 10 years before the youngest relative was diagnosed. Epidemiological trends in the distribution of colorectal cancer, the birth cohort effect, and effects on participation have shown a notable increase in colorectal cancer incidence and mortality in people under the age of 50. And there is now published evidence on the benefit of lowering that start age. And so they did some modeling, and it was conducted to estimate the lifetime and program impacts of lowering the screening start age from 50 to 45. An expert panel was gathered that Ontario Health had held in January of 2026 to contextualize the evidence and provide input on the proposal to lower the starting screen age for FIT. And so here in the last 10 years, the incidence of early onset colorectal cancer, so people's age 25 to 49, has increased while it has decreased in adults aged 50 to 74. People in Canada born after 1980 are 2 to 2.5 times more likely than previous generations to develop colorectal cancer before 50 years of age. And so while incidence is increasing in younger people, it still remains low compared to people aged 50 to 74. When you look at incidence rates for colorectal cancer over time across generations, you can see the incidence of colorectal cancer has risen in each successive birth cohort, starting with Generation X. Specifically, there is a birth cohort effect where compared to people born in the 1950s, people born after the 1980s have a higher rate of colorectal cancer. And this is shown in the upper inflection of the graph on the right. This slide is to demonstrate that the colorectal cancer incidence in younger people aged 35 to 59. And so this is from Statistics Canada to compare incidence of colorectal cancer across different age categories in Canada. If you focus on the red and orange lines, you can see how incidence in the younger age groups has changed over time. Looking specifically at the red line, that's people aged 45 to 49, the incidence of colorectal cancer is higher in this group compared with younger adults and has seen a bigger jump in recent years, starting to increase closer to the incidence of people aged 50 to 54. Therefore, by lowering the screening start age from 50 to 45, we're targeting the population that would benefit most from screening. Compared to other people from Ontario, First Nations people have a higher cumulative incidence of colorectal cancer and are more likely to get colorectal cancer at a younger age. Lowering the start age will potentially contribute to an improvement in early diagnosis for First Nations people. Ontario-specific data was used to model the impact of lowering the screening start age from 50 to 45. The findings were used to inform the decision whether to make the policy change. The findings show benefits in life years gained and a reduction in colorectal cancer incidence and deaths. Specifically, 50,440 greater person years of life were gained, 11,130 fewer cases of colorectal cancer, and 4,120 fewer colorectal cancer deaths. This is based off modeling data. We have not seen this because we just started the program on July 1st. And so starting July 1st, just 2 days ago, people aged 45 to 49 can start screening with FIT. Invitation letters will be phased in over a 2-year period for this group. However, people aged 45 to 49 who meet the program eligibility criteria starting on July 1st, even if they have not received an invitation letter, can avail of this. With the lower screening start age, primary care providers are encouraged to initiate screening conversations and complete FIT requisitions for people aged 45 to 49. For those who get paid through OHIP, there is a billing code for that. It's Q150. Colon Cancer Check Program has updated clinical resources, requisitions, and the frequently asked questions to assist primary care providers in adopting the program changes, including communicating the evidence for lowering the age and supporting patient understanding. Primary care providers should also be aware that with increased FIT participation, you will see more abnormal results requiring follow-up and colonoscopy referrals. For those at increased risk, after reviewing your patient's family history and determining they meet the increased risk screening eligibility, you can start ordering colonoscopies for eligible people at age 40 or 10 years earlier than the age of their youngest relative that was diagnosed. Let's go over some family history considerations. As before, everything in purple is represents what has been changed on July 1st. So as of July 1st, the program changes to the definition of average and increased risk as it relates to the person's family history has changed. Specifically, people with one first-degree relative diagnosed with colorectal cancer at or after 60 are now considered average risk, not increased risk. The new screening recommendations for people with family history of colorectal cancer were based on a review of the published evidence on the impact of family history of colorectal cancer risk, as well as a review of guidelines, data showing the impact of family history on colorectal cancer risk, which will be reviewed in the upcoming slides, an expert panel that was gathered, and they held an international multidisciplinary expert panel in 2020 to contextualize that evidence. And there are additional slides if you are curious in the appendix. Let me know if you want me to go over those later. So over the next few slides, I will summarize research that examines the absolute risk of developing colorectal cancer by age 85 by different colorectal cancer family histories. The risk is compared against the general population risk of colorectal cancer in European and US populations. So looking first at the definition of family history, people with one first-degree relative diagnosed with colorectal cancer at any age, while the absolute risk of developing colorectal cancer by age 85 is about 1% higher than the risk in the general population. This difference is not statistically significant, and the 95% confidence intervals are quite wide. Just to put that again, so if we look at any age, one FDR, and we look at the general population, you're seeing that it's a very small takeaway and it was not meeting statistical significance here. Here, when we're looking at the impact of family history, we're seeing that there's a general population risk across the top, those with the one first-degree relative at any age, and then they split it into two, those who were diagnosed less than the age of 60 and those diagnosed less than the age of 50. And as you can see here, those with relatives diagnosed with colorectal cancer less than 60 years of age had a significantly increased risk of developing colorectal cancer screens, which is why they chose to say that anyone above 60 was average risk. And then finally, that last bit there in terms of two family first-degree relatives with colorectal cancer, that's with any age. It's because that patient would be at a higher risk than the general population. So a large population-based randomized controlled non-inferiority trial involving 57,000 patients looked at colorectal cancer mortality at 10 years compared to one-time colonoscopy. And they found that people who were offered FIT had a higher participation rate compared to colonoscopy. When we look at intention to screen basis, which is based on real world aspects, FIT is comparable or statistically non-inferior to colonoscopies in detecting colorectal cancer and in reducing mortality because of colorectal cancer. So when screening with FIT, fewer people need colonoscopy to find the same number of cancers, which helps to limit the exposure of the risks to colonoscopies. Colonoscopies are not completely benign. There is risks in terms of the procedure preparation, as well as with perforations, which I have had some patients with, and infections as well. And so in this case, we're looking at first-degree relatives with a colorectal cancer of less than 60 or two first-degree relatives of any age. They are significantly higher. They need a colonoscopy. But if you have one first-degree relative diagnosed over the age of 60, the risk is similar to the general population. Therefore, it's a FIT test. In terms of screening intervals, it remains the same. It's every 2 years. When we're talking about the increased risk population, they've changed it so that it's now 5 years for somebody with the family history piece, whether that's one family first-degree relative less than the age of 60 or two first-degree relatives of any age. When we talk about screening cessation, when should we stop? So previously for the FIT test, it was 74. It remains 74. For the increased risk population going for colonoscopies, before there was no formal recommendations, and now they've actually said 74 to align with the average risk population. And so with the new formal screening cessation recommendation for people at increased risk, all CCC participants should stop routine colorectal cancer screening after the age of 74. This is because people over age of 74 do not benefit as much from screening and are at greater risk of having complications when they get screened for colorectal cancer. However, people ages 75 to 84 can choose to get screened through a process of individualized decision making. They should consider whether the benefits outweigh the risks through an informed discussion with their provider, considering their overall health comorbidities, life expectancy, previous screening history. Screening with any modality is not recommended for anyone over the age of 85, and FIT requisitions will be accepted for people 44 years of age or older up to the age of 86. Requisitions will be rejected for people less than 44 or 86 and older. Any questions about that before I move on? That was a lot. Okay, I don't see any hands going up, which is good. And the chat remains empty, which is good as well. Perfect. All right, let's talk about some changes. And I think this is a big part of why folks are here today. There are some new FIT partners. One, contracts with the previous laboratory and FIT device vendor were expiring in 2026 and had to be reissued. To support this continued testing and distribution, Ontario Health released two, they're called RFPs, or requests for proposals. And I can go into details as to what that means later on if you're interested, for qualified FIT test system vendors and laboratory service providers. And so the successful folks were Micrognostics, and that's going to be the FIT device, and then In Common Laboratories as the new lab service provider. ICL is a Canadian not-for-profit that has been supporting laboratory testing and patient care since 1967. And you can find more information about them at icllabs.ca if you're interested. Starting July 1st, so 2 days ago, there's been an updated FIT requisition. A custom form has been made that can pre-fill it for those on TELUS Practice Suite solutions, and I've been told it's been created for Oscar and Acuro as well. If you don't have it, either reach out to Ontario MD or reach out to myself, and I'll see what I can do to get it for you. You must set up an account with ICL. So if you've submitted a FIT requisition to Life Labs within the last 2 years, ICL will proactively create your account before go live. You may be contacted to confirm your details. If you had not submitted a FIT requisition to Life Labs in the past 2 years, your account will be automatically created the first time you submit the FIT requisition. So that account setup is required for each working address and location and fax number. You'll need to verify your fax number if you have not ordered a FIT from Life Labs in the past 2 years, or ICL had to contact you to confirm your fax number. Fax verification is a one-time short process, and ICL will fax a verification form to you. You must sign the form and fax it back to ICL, just like how we all had to do it for Life Labs and Dynacare. If you use multiple fax numbers, each will need to be verified separately, and that's because of privacy issues. In terms of receiving FIT results, all FIT results will be available through OLIS, which every EMR should be connected into, or every Ontario MD certified EMR should have the ability to connect into. But you also must also have a direct reporting method. Fax is that default method. Other direct options include EMRs with the provider query functionality, and there are 3 that can do it. They're not the main 3 though. To receive FIT results by mail, you should email ICL's FIT support team. I'll throw the email address if you want to buy snail mail. If you have any questions whatsoever, they have a call line. It's 1-833-FIT-POOP. I'll throw that in the chat as well. ICL will process requisitions and test completed FIT kits, even if the fax verification is pending. However, you will not receive fax provider reports until the fax verification step is complete. Those results will be in OLIS. For primary care providers who wish to receive FIT results via EMR, Ontario Health is working with OMD certified EMRs to make FIT results directly available in EMRs. Not all EMRs have this functionality at launch. So in the interim, FIT results will be sent by fax. If EMR is your preferred reporting method, please visit this website I'm going to throw in the chat to indicate which OMD certified EMR you use so that ICL can switch you when that method becomes available for your EMR. OMD is requesting that if you have questions about this functionality, contact your EMR vendor directly. As mentioned, there is a new FIT device. This device is being used in jurisdictions around the world. Generally, the new device is similar in size and shape to the previous device, and the key difference is the closure mechanism. Previously, a lot of my patients didn't know you had to really push it closed, and this makes it easier. The new device has a twist to close cap, which is easier for participants to close tightly, and we expect that this will reduce the number of leaky specimens. We've updated the instructions to reflect the new device as well, and to get feedback from participants. The illustrated FIT instructions remain word light, relying primarily on visual depictions of the steps. FIT instructions are available in both English and French in the FIT kits that are mailed out to participants and are available in 30+ languages online. If you're interested in having those different languages, here's the website to access them. Here we go. FIT is a take-home test, and participants have up to 12 months to complete and return the test before the requisition expires. As a result, FIT kits distributed by Life Labs will continue to be returned after July 1st. Life Labs will test those devices during the 1-year transition period. So up to and including June 30th, you could have ordered these FIT tests and sent it to the fax number for any replacements or anything like that. FIT devices distributed by Life Labs should continue to go back to Life Labs. And after the 1-year transition period, devices distributed by Life Labs will no longer be considered valid. Any Life Lab FIT device received after 1 year will not be tested. As of July 1st, all FIT kit orders to ICL using the new ICL branded requisition and fax number need to be done. This includes requests for replacement devices for a device originally mailed by Life Labs, or if the initial test was unsatisfactory. Participants will return ICL distributed kits to ICL either by mail or dropping it off at a Rexall location. Perfect. So if a participant receives an unsatisfactory, either rejected or invalid result for a device mailed by Life Labs after July 1st, they will receive correspondence from Ontario Health informing them of that result and telling them to go contact their primary care provider to get a new FIT requisition. You will also receive a result report from Life Labs indicating the unsatisfactory result and the need for a new test. You should submit the new requisition to ICL for anyone who receives an unsatisfactory result. With the transition to the new lab, we're also making some process changes based on feedback from you to help to improve the provider experience and increase screening participation. These changes are covered in Module 2, but I actually brought them up a little bit earlier. But essentially, the labs will automatically send a new FIT kit to participants whose FIT was rejected or produced an invalid result. A new requisition will not be required from you in most cases. The only time it would be required is if there's a transition from Life Labs to ICL. Letters have been updated, and they're introducing a new letter that will highlight that we're going to show in the upcoming slide, and improving result reporting messaging for primary care providers so that you're not trying to interpret what does the message mean. So automatic sending of new FIT kits after a rejected device or invalid result. If a participant completes their FIT incorrectly or they have an invalid result, ICL will send them a new kit without requiring a new requisition, as long as the original requisition is still valid, which is 12 months. If more than 12 months has passed since you submitted the original requisition, or if the participant has unsuccessfully completed 6 FIT kits, you'll need to submit a new requisition. In terms of communication from ICL, it will be more clear. It'll be more specific in regards to the result being rejected or invalid, and generally informed to reflect feedback that primary care has provided. This is a question that comes up often, which is why can't we distribute FIT kits? And so the central distribution model allows for us to remove a lot of those issues that cause rejected tests with the FOBT testing. So they're pre-labeled the patient identifiers so that there's no confusion or rejections. And the tests are mailed within 6 months, with at least 6 months before the device is expired. It supports timely and appropriate screening, and requisitions are checked for age eligibility and most recent FIT by results, so people aren't being screened inappropriately. So in order for your patient to get their FIT test, make sure you have the address, please. And you can send them, I have a few patients who send them to my office, and then they come and pick them up, especially if they are between homes or are transitioning quite frequently. Ontario Health will send reminders if their kit has not been returned within 2 months, and that is something completely brand new. So if you have not seen a FIT result for your patient after 4 months, consider following up with them if you'd like to, directly to remind them to complete their test. Please do confirm their OHIP number. Confirm that you have the right rural road, postal codes, PO boxes for individuals who live in a rural area or use a PO box as well. Oh, and FIT kits will only be sent to within Ontario. Forgot to mention that as well. As most of us know, this is an at-home stool test. It requires only 1 sample, and there is no dietary or medication restrictions. I have patients who take iron pills who do these tests, and they come back normal. It checks specifically for blood. Completing a FIT is really easy. Check the label for accuracy, record the specimen collection date, complete the test, and either mail it or drop it off at a Rexall location. And then, as I mentioned, there's an automated process for invalid or rejected FITs so that it decreases the administrative burden on all of us. And a reminder to your patients, especially if you're getting 2 or 3 invalids in a row, is that to drag the stick across the poop until the grooves are fully covered, and the stick should be put in the tube and twisted shut. There is such a thing as too little or too much poop as well. So the ICL cannot analyze FIT devices with too much stool, and so it is really important. Oh, sorry. Some of you, if you don't mind putting yourself on mute. As always, just remind them to label their device, and results are invalid if they cannot confirm the collection device and result is below the positivity threshold. So, resources. We have some supports for patients. 1, invitations, recalls, reminders, results. That reminder letter is brand new. This is going to help us a lot. Number 2, we have proof that shows that physician-linked correspondence. So that's the letter that the patient receives. If you give permission to Ontario Health to put your name at the bottom of those letters, it increases the participation rate. It's really easy to do. All you need to do is give them permission to use your name on those links. I'm going to try and pull that link up for you. Give me 1 second so I can share it with you. There you go. In that reminder letter, it will be sent after 2 months, and the letter includes information on colorectal cancer screening and motivational messaging. And we're hoping that there'll be more kits returned, fewer rejections for expired kits and requisitions, and reduced workload on all of us. They've updated the colorectal cancer screening fact sheet. And for unattached patients, eligible patients without a primary care provider can call Health 811 and be sent for a FIT kit. That's the same phone number where patients can sign up for Healthcare Connect. Currently, we are at 0 officially. We have no patients on Healthcare Connect, and we have about 30 to 40 clinicians, last I checked, who are accepting patients. And so if the patient has an abnormal FIT test or needs a colonoscopy due to family history, Ontario Health will find a primary care provider who can refer them as well. For yourselves or all of us, the updated FIT requisitions and instructions are available online in the link I shared earlier. There's new updated frequently asked questions on the website, provider tools, and FIT instructions that you can download online. There's a screening activity report. That screening activity report is available to anyone who works inside of a FO or a patient enrollment model. In those cases, you can actually see what your screening rates are and track that over time. We also have a program right now. There was a link that was shared through the newsletters as well as in the group chats in regards to having a student in your office to get cancer screening rates up for yourselves. So please do go back, find that link, and sign up for that. For those who identify as First Nations, Inuit, Métis, and Urban Indigenous, there are self-paced courses for providers who take care of these individuals. It's free of charge, and they're accredited up to 19.5 main pro credits, which is a substantial amount. So a total of 13 courses, and you can access them all online. So if you need credits, this is a great way to learn about something new that I certainly was not taught back in residency or medical school, while also being able to provide more culturally appropriate care to our patients. If you have any questions, please do feel free to email us. I do realize I did not put in my email address there at the end, so here's my email address should you need anything from me. And that's the end of the presentation. Any questions? I know it was a lot of information.
I'm not seeing any, Neil, but thank you so much from the RCP for making this presentation available to everyone here and also regionally.
Thank you so much. It's my pleasure. I thought I saw somebody typing, but all good. Thanks, Greg. I must have done a great job if there are no questions.